fast. Some people might blink and their eyes may wobble. Some people will twitch violently. Some people might look like they're going into a seizure. I had a client who was first sexually abused at the age of 4. And I go like this. She finds a spot. And the first thing she does is scream, "Don't hurt me, don't hurt me." And she starts processing, and she's wobbling her eyes, she's clenching the teeth, she's raising up the shoulders, and in the middle of the session she starts talking like a 4-year-old.
Disassociate.
Well, she's going to that time, so she's going to that ego state, you know, at the age of 4, and she's literally talking like a 4-year-old. Body language, verbal communication, and everything in between. And you know, I hold the pointer there for 60 minutes, and she's processing and processing and processing and processing. So what we're doing with the technique is we're liberating the trauma. Okay? And I recommend that you look into it. It's a fairly new technique, but it's very, very useful. And what we're doing now is I traveled to New York, where David Grant is based, and we ran two studies looking at the EEG while people were doing brain spotting. So we connected QEEG 19 channels and physiological variables, just like you do in stress profile. And we're going to be publishing that data really soon. So for the first time, we're seeing things. And I noticed some interesting things. People who had a lot of FC, cingulate gyrus activity, when they were doing the process, you see the desynchronization of the brains. Now, we only measure it once. We need to do more consecutive measurements, but it's a really interesting technique. Sometimes with trauma clients, I will go to brain spotting first, and I help them release the energy, and then I go into neurofeedback. Because I noticed that it's not until they renegotiate the trauma that neurofeedback will not work for them. Some clients I will do some neurofeedback first because their brains are flexible enough, and then they will go into brain spotting. But everything I do is combined. Now I don't do one or the other. I always use both, regardless of the type of trauma. You know, I broke my arm, or I was raped, to I was held hostage, to I was kidnapped. Anything in between will really help. And the other thing is, just like neurofeedback, you can do peak performance work. So it also works for finding spots for peak performance in athletes. So if you're curious, I can after we're finished show you the information and everything else. But it's really, really interesting work. Are there any other questions? No? Okay, so go to.
We talked a little bit about neurofeedback and biofeedback, and I'm going to go straight to the case studies. We've got about an hour and a half left-ish. How's everyone doing? We're good? Cool. So I'm going to do a couple of case studies, and rather than give you the PowerPoint piece of it, I'm going to talk about neurofeedback and biofeedback as I go through 2 treatment cases. Okay. First one we're going to talk a little bit about is someone that I did a lot of biofeedback with. Okay. And this woman's name is Shelley, and she was a Texan, and found herself walking to her car at night from her office, and was mugged and raped and beaten severely. Had a pretty traumatic head injury in addition. And so she came in, this is what she looked like. This is her stress assessment when she first came in. So when she first came up, she was up in Traverse City, summering, and wanted to kind of do a little bit of work. So we did and I knew that she had already kind of given me a piece of her stress. So let's have a look and see how things are going here. So this was her stress assessment, and again, I'm starting to do a stress assessment with her because I want to know how she's expressing her stress, knowing what she's been through, trying to kind of figure out how I'm going to assess her and what I'm going to do with her. This is step 1 for me. QEEG is also another step in looking at the brain. But in this case, due to her resources and time, we decided that we were probably going to work on the physical pieces of it. She came in with a lot of body pain, a lot of somatic complaints, headaches, and was really just afraid to be out a lot. So just being able to come to my office was a bit of a stretch for her. And this was causing a lot of trouble in her marriage, as you can imagine. When you've got someone who's that constricted, can't go out, having a lot of somatic complaints. It was a big act of really courage on her part to be able for she and her husband to come up and summer up in Traverse at their, their lake house. So, we put everything on, and usually when I do a stress assessment, now here's something that you need to think about. We talked a little bit about hand temperature earlier, right? And we talked a little bit about this idea of paradoxical temperature response where, they'll sit through the whole stress assessment and their temperature will go up. If you don't habituate the person to being able to have all of these wires on you, what you're going to see when you begin to do this stress assessment is a stress response, not to the stress assessment itself, but the stress response to the equipment. So one of the first things that I would suggest is when you do this, hook them up, sit there and do your intake interview or whatever that you need to do for about 10, 15 minutes and just kind of let them sit there and let them get used to it, let them habituate, because then your stress test is going to be so much more accurate. So this woman, I'm looking at this. The very first thing we do is we do a baseline assessment for about 2 minutes. Again, she's already been sitting in the equipment, so I know that she's comfortable. She's kind of gotten used to it. It's not a novel thing to have the equipment on. She doesn't look too bad. You can kind of see there's a nice little relaxation response here when we start it up. You see how the skin conductance goes down, right? She's on guard. I mean, she walks around, kind of like this. And then we do a color words test. So this is like the Stroop test. So this is where a word flashes on the screen, and let's say the word is blue, but it's written in orange. She needs to say the word orange, not blue. And this is rapid fire. Boom, 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 boom. You can see she's a really high ramp up to this. And you can see what happens to her muscle tension. I mean, she's already walking around like this, or she's really like this now. In terms of looking at respiration, heart rate variability during this particular task, I don't, because they're talking, and so that's going to completely throw off your results. So you're not going to do anything. Okay, so how does she come down? Well, her muscle tension comes back down to where she thought. Skin conductance stays up. We're going to talk about temperature in a minute. Temperature is kind of a slow-moving signal anyway. You can kind of see it's flat here, but I'll readjust this here in a minute. We can kind of have a little deeper dive into temp. Math. This was a serial sevens task, so I say take 2048 and start subtracting 7 from it as fast as you can. And the math task can be really dialed up or dialed down completely. Let's think about that a little bit. So this is a woman that's already been seriously traumatized. And if I give too much to her too fast, too hard, she's just going to check out and dissociate. That's all she's going to do. And think about a kid with a learning disability. I used to do this with my troubled kids, my juvenile delinquents that I worked with. So if I gave my 14 or 15 or 16-year-old juvenile delinquent kid, probably had some head injuries, probably had some toxic exposure, probably had some gang fights, had a lot going on in his life, learning issues. If I gave him, start at 2048 and start subtracting 7s, he's just going to... I watched this. This is how I learned. Don't do it. Don't do this yourself. Okay, well, I can tell you how I first stepped it. It was giving that to a kid and just kind of watching him go, I can't do that. He just kind of sits there. So think about how far you're going to dial up the math task. With my kids, sometimes it's counting by 2s is stressful enough for those guys. So you have to think a little bit about the fact that you're trying not to disassociate people. You're trying to get them to move through a mild stressor, but we don't want them just to check out and give up. Okay? We know they'll do that. So we want to see what they can do when they can perform, when they are capable, what a stressor looks like. So she ramps up a fair bit. She has a little bit of reactivity in the muscles. Not too bad. Again, she's talking here. What happens here, you guys? This is the relaxation period after the math task. What's going on there?
She's wondering how she did.
She's berating herself. Yeah, exactly. And you can see what happens with the muscle tension right there too. There's a little flinch. I mean, she's protecting herself. So that was all good. Now, during the stressful event recall, I specifically tell people, think of a mild stressor. Don't think of your most traumatic stressor. But sometimes people don't listen so well, and she was one of them. Because I'm sitting here watching her, and usually I don't say a word. Usually I say, just kind of think about it in your head. And I'm really watching her. I'm watching her face. I'm watching her eyes. And it's clear that whatever she's thinking about is not a mild stressor. And so finally, you know, I'm kind of saying, okay, it's okay, you know, it's okay, we get through it. So we get through the end of it, she rests, you can see the response of the rest over here. I said, what were you thinking about? She goes, I was thinking about getting raped, I was thinking about that episode. And, you know, that was you try your best to kind of protect people. Needless to say, after we did the stress assessment, before we processed it, we downregulated that physiology. We did it by doing breath work and doing some heart rate variability. When she was back down to baseline, then we went through and we talked about the stress assessment. So what did her protocol look like? So there's some things I could do with her. Go back over here. So some options I have on the table here. Obviously, heart rate variability is a very, very top of my list too. I mean, seriously, the top of my list. And temperature biofeedback. Now let's go take a deep dive into that temperature really quickly here before I get too far gone. Okay, so let's just adjust this here. No, I've lost it. There we go. Let's just kind of think about this one right here. She is so flat on her temperature, it's crazy.
Linda, can I ask a question about the skin conductance?
Absolutely, yeah.
Because it looks like it's only going from about 2 to 3 Siemens.
Yep.
So I've also had some clients that seem very anxious but show this very tiny.
Yeah.
And I'll often talk about, well, let's look at the pattern rather, but that's so small.
It is, and I can speak to this really, really well because if you do skin conductance on me and I'm really anxious, I'm down there, but my skin is super dry.
Well, that's, yeah.
Yeah, so you really do have to look at percentages here. And if you put lotion like aloe vera, that really helps. I'm terrible about it. It's awful. It's embarrassing. It's like I'm dead or something.
Or a sociopath.
What's that?
Or a sociopath. They don't respond about it.
Can I say something about that? I've noticed that some of the people who are highly activated, apparently, but have their skin conductance is not as high or the temperature is as flat as that one, is they're either doing constriction or dissociation.
Yeah.
They're suppressing, they're trying to suppress emotion. That's why you don't get a lot of activation like that.
Yeah. So I had to take this down to a very narrow place to see this. And she has a slight stress response, very, very slight. But her temperature, if we look at the scale, see if I can get my little pointer over here. It's not going to give me any numbers. Her temperature is at, looks like it starts out at about 70, just under 74 right here. So her hands are cold to begin with, and they get a little colder. So her temperature might be something. This is summertime though. I mean, this woman's hands are that cold.
So is what are her hands, room temperature then?
What's that?
Hands were room temperature?
Yeah, yeah. And I don't.
They can actually get below with perspiration.
Yeah, yeah. I don't keep my office too cold because I hate air conditioning, so people have to suffer. So my options, I can do some heart rate variability, that's number one. Temperature biofeedback. But the other things I'm going to concentrate on, skin conductance and surface electromyography. It's interesting that doing something like this will help people immediately start to relax this. Now, she had some other somatic pains up the back of her neck, and so we spent some time really just working on not only the co-contraction, the asymmetrical contraction you see there, but really just kind of down-regulating. And what that looks like in terms of SEMG biofeedback is, first of all, I want to teach people to contract to a period that feels like it's close to 100%, and then down to as relaxed as they can get, teaching them to come down as relaxed as they possibly can, And then I wanted it to contract to 50%. Because a lot of people who are having that kind of tension and pain don't know the difference between 50%, 75%, or 100%. And then I want them to do it at 25%. So we're doing straight SEMG biofeedback, just kind of looking at a nice little line on an oscilloscope and some numbers, and they're practicing my contraction. The other thing that I'm doing is, have you guys ever seen those little colored dots that you can get over at Staples, as these little stickers? Those are great. So stick one on your rearview mirror, stick one on the medicine cabinet, stick one on your refrigerator handle, and anytime you see that, I want you to do a body check. So she was doing quite a lot of body checks. Now, in terms of heart rate variability, I did something with her a little bit different. I wanted to see what she looked like during the day. So Santiago talked a lot about the frequency domain and kind of we started to get into the time domain. So frequency domain is a nice composite of, okay, if I'm sitting here in the office and I'm doing a session, this is where I'm at. But if I look at time domain, I can start looking at what changes over time. Now, this is Kubios, and what I did was I put on her for a day this little handy dandy Polar strap, and I send the people home with a little V800 sports watch and a Polar strap, and it records their EKG, and then I can dump it into this and kind of have a look at it. So let's just think about this a little bit. This was right after the stress assessment. I sent her home with it. So this is a 14-hour day. This is 14 hours that she had it on. To look at this, what you're looking at here is the Kubios version of the sympathetic stress index and the parasympathetic stress index. Those are basically a composite of several different items. So, for instance, the PNS, the green, is a composite of root mean squared, RMSDD, which is a time domain measure, and L low frequency. And the stress index takes Babsky's stress index. Babsky was the Russian cosmonauts. Anyone know Babsky? Yeah. So it took his stress index, took SDNN, and took heart rate. So it's a combination. They created an algorithm to come up with the stress index, and it's pretty nice. I can actually show you this. I can show you the RMSDD and the stress index. It lines up pretty nice with what Kubios is doing here. So I have a 14-hour day. When she started out, this little period right here and at the very end of the day was the only time that she really relaxed and moved out of that stressful place, which is helpful to know. So then you take something. Let's see if I can put it over here. Yeah, let me grab this together. And I'll actually pass some of these goodies around. So
So it's hard for me to read that, but the red is her sympathetic?
Yeah, the red, so if anything over the 0 line is more than would be anticipated or should be, and anything below is less. So you can see that she's almost in the red almost the entire day except for a few moments.
Okay.
Yeah, that's what I want right there as a zipper case. Yeah, thank you. So knowing that, I'm going to send her home with some homework because there's just so much we can do in the office, right? And I'll pass this around if you guys want to kind of play with this a little bit. So this is, and there's a lot of different toys. This is the EVU. What I like about it, let's see where my skin conductance is. So if you want to play with this, I'll just pass this around. But if you hit practice, it's going to find my little guy. And it's going to give me about 64 seconds before it cranks up and goes. So I'll have to wait a little bit. But the nice thing about this is that I've got heart rate variability, just real simple. Skin conductance, which I really kind of wanted to work with her on, and temperature. So sending her home with this so that these moments where she's looking like this, we can have more of the green above the 0 line and less of the red. So slowly it'll start, 34 seconds from now. So part of what we're doing is we're doing heart rate variability biofeedback in the office. And while this is going, I'll just kind of bring that up here so you can see what that looks like. Again, super simple. My stuff's scattered all over the place. So this is actually, this is not what I usually start with. I'm pretty sure this. I use this a lot.
And is this the one that comes with software?
It's the one that comes with a thought tech, and I made a lot of my own screens, and I just kind of keep coming back to it because it's kind of just what I need, and I haven't modified it. So I'll show you this about the homework piece of it, and then we'll go into that. So at home, she's doing her heart rate variability. She can scooch over here. See, I'm at 1.95 right now on my skin conductance. So it's not very good. So she can switch over. She can do her biofeedback at home, and be able to practice it, especially when she's feeling stressed. I'll let you guys have a look at that. That's one of the tools I use. The other tool that I use, if people don't have the resources or they have an iPhone or something like that, I'll pass this around too, is this is called HRV Plus Coherence. It's an app that you can get. I love it. The problem with this, it uses the photo sensor on your tablet, and if you're not really still, it's a bit tough. But if you just put your finger on the sensor back here.
Which one do you use?
This is HRV Plus Coherence.
Okay.
Yeah.
That's the one I use.
Yeah, I've tried Elite HRV. And a couple of others, and this is the one it's been kind of nice. So tap to start, and it detects my pulse, and when it finds it, then I've got a breathing pacer, and it's going to show me a level of coherence. I like this because, I want to give people, it's great that you're coming to my office to do this, but, guess what? Usually most of the stress isn't happening at my office. It's, hopefully not, it's usually happening at home. So once we get going here, I'm sure I'm not very coherent because I'm talking. I'll let you guys kind of check that out. I like the pacer on it. I'll let you guys, I'll pass it over here. There you go. All right, so we haven't even talked about, we're just trying to get the sympathetic nervous system regulated. So we're trying to work with achieving heart-breath coherence, trying to shape the breath and pace the breath. I almost always start here,
I've seen this one.
and I almost always start with just the respiration. So I get people to make a nice shape of their breath and start to breathe somewhere around 5 to 6 breaths a minute. I don't even do a resonant frequency assessment at first. I say put 3 mountains on the screen. When they do that, then they can come over and they can look at their interbeat interval together, and almost invariably, if I've gotten their breathing in the right place, then they're going to be able to make some nice coherence here with their breath.
Well, she has inverted peaks.
What's that?
The peaks coming down on the first
Yeah.
breath there.
Yeah.
It's inverted.
Under that app you showed us, Heart Rate Plus Coherence, will also work with the chest drum.
Yes, it will. It'll work with that one. I love that. The only thing is, if you're going to do long recordings, it won't work. Short recordings are great, but you'll
See, they flipped already.
What's
See,
that?
she has scallops up instead of scallop turned
Yeah.
around on the
Yeah.
exhale.
Yeah. Yeah, so this was not the perfect session, but this is.
But you can also see how fast she was breathing.
Yeah.
Those
Well,
are
she's doing
inhales and
actually pretty
exhales.
good. She's breathing about 5 breaths a minute.
But those are the old ones.
What's that?
The scallops are the old breaths.
This is the blue is your breath.
Yeah.
Yeah, so she.
It shows up in the heart though.
Yeah, this is your heartbeat. So
Right.
the heartbeat's speeding up, the beat's speeding up.
Yeah.
And then as she goes, see the beats coming down. That was a nicer breath, slow down. So that's what I'm trying to get, though, is at least getting some coherent breath and practicing. And this was a session in the middle of everything, so it wasn't the beginning and it wasn't the end. Most people can't do it that well. So we haven't even started talking too much about the trauma. More than anything else, I'm trying to get her to downregulate that sympathetic response. That's the very first thing I want to do. I'm trying to get her to recognize her body, work with the somatic symptoms, and downregulate that. Next stage. Now we need to start talking about working with some of the things that's getting her coming in. In addition to doing neurofeedback and biofeedback, I do some EMDR, but I'm really careful with that because I've also seen where it's kind of like getting a hammer. Is anyone doing EMDR here? Okay, you are. So it's often not my first go-to. It really is like getting a hammer. I can use things like alpha-theta neurotherapy and be much more subtle and work the trauma out, whereas EMDR can sometimes really push people over the edge, and I really want to be careful about that. So next piece with anybody who's doing work is we're going to do a safe place. And I'm going to talk about this a little bit more when I talk about alpha theta, but in terms of the safe place, that's the next piece I'm going to do with her, and then we're going to do some EMDR and start working out that trauma. But with a safe place, I do this even with neurofeedback, and even if I don't do EMDR with somebody, it's a nice piece of that therapy that I've kind of pulled out and just kind of integrated with everything else. So the safe place is where I'm inviting people to have a visualization of a place that's very comfortable and safe. And I want them to do that because if I'm doing any therapy with them, be it neurofeedback, be it biofeedback, be it EMDR, whatever, if we get into that part where they are having a stress response and an abreaction, then I want to have a common language with that client so that we both know where we need to go. So I'm going to spend some time with this, and I'm going to do a short and safe place often at the very beginning over a number of sessions because I really want, it's a common language. We have a word that we both know. So what is your safe place? What's your title? Mountain. Okay. We both know it. We're always going to use it. I write it down, they write it down. We always use it. And we always know that if I say you need to go to the mountain, that's time to stop. We're done with our piece of the therapy session right now talking with the trauma. We're shifting to the mountain. It's that I can't tell you enough how important it is to do that regularly. I tell the clients a lot, and the reason I give equipment is, you know what, I can sit here and I can show you how to breathe, I can tell you how to breathe. It's kind of like giving someone a bicycle and say, hey, you take this great thing, you pump up and down, and it's going to get you to work. Here you go, see ya. And no one practices it. What are they going to come in and say to me the next day? That bicycle didn't work. So that's why you need the gear. That's why you do the safe place over and over and over and over, because that's the only way they're going to be able to integrate it. So, in the safe place, these are some of the things that the points I hit. And I actually gave you a couple of things, some of my favorite visualizations. But usually, I come in, find a place. Usually, I say it's outside, and they'll come up with their own. Usually, kind of have them visualize coming in, walking around in their mind, getting comfortable and settling in. I want them to use all the senses that they can. I want them to smell it. I want them to feel that safe place on their skin. And I want them to think about, what's the time of day? Is it windy out? Is it nice and warm? What does that look like? And I'm also going to start tying that back to the breathing, which we've already been doing. So biofeedback intervention, not doing any neurofeedback, but we're doing the safe place, and we're tying it back to the respiration while she's doing the homework that you guys are passing around there with devices. Then we're going to move into EMDR. With her, that's where we needed to go. Our time was limited, and that's kind of, as she and I spoke, what needed to happen. So we're starting to work this out. By the time they left for the end of the summer, she was getting to the place where she could allow that trauma to have occurred and not have to have been kidnapped by it. It was still, there was still a big sting. It was still very prominent and fresh. But she was to the point where she could use her heart rate variability. When they need to go out to the restaurant, she could sit in the car, they could do a little bit of that. She could kind of do a little bit of pre-training, be able to go in, have dinner with her husband, go out in public. And I felt like for her, with all the somatic symptoms that she had been noticing, that was a good place. Her somatic symptoms had gone down. She was not getting the tension headaches anymore. We worked so that when she went back, that we referred her to a therapist down in Texas so that she could continue some of the therapy. So let me just give you a few benchmarks here that I work with skin conductance and temperature and so forth, just so you have them. So here's some nice ones with temperature. If you're looking at someone with really cold hands, they're below 79 degrees. Remember, she was about 74-ish. Deeply relaxed is going to come into play when I start talking about the next case. I'm going to talk a little bit about the Peniston protocol, which is actually not a full-on neurofeedback protocol, but a multimodal protocol that used both neurofeedback and biofeedback. So this is PowerPoints with your in your materials. So first thing is, I want to teach them how to be, at least just become aware of their body. So we're going to what is your temperature? Then I'm going to get them to see if they can relax enough to raise it and then lower it. So building that flexibility. By the way, do you know what a really nice home biofeedback tool is for temperature that costs almost nothing? What?
An outdoor thermometer.
Well, there's an even better one. Chocolate.
Oh,
No, I'm serious. And you get to eat it afterward. So milk chocolate has a lower melting point than dark chocolate. Dark chocolate, the melting point is right around 95 degrees. So and we're talking about the good stuff. We're not talking about the cheap stuff. So if you want to have someone practice this and you want to make sure they practice it, make sure they don't have migraines or a chocolate allergy or something like that. It's not so good for that. But go get yourself a piece of chocolate, take off your square, gently hold it in your hand, do your relaxation exercise, and when that chocolate melts, then you may eat it. And that's a really nice way of getting people to consistently.
What's the temperature for milk chocolate?
I think it's around 90, actually.
So you have to use
quite
dark
close. What's that?
You have to use dark chocolate.
I recommend dark chocolate because it's the one that has the higher melting point. Milk chocolate's kind of variable depending on, like Hershey's bars, they'll melt. You just breathe on them, they'll melt. So dark chocolate's better. I'm going to teach them to sustain their temperatures for longer and longer periods of time. I'd like to see them be able to do it for 20 minutes or so. Now think about this a little bit. And the reason I like to use the chocolate piece of it is if you are disengaging your cortex and making yourself relaxed enough to open your capillaries, you better not be engaging the executive network. Because as long as you're thinking about whether that temperature is going up or down, it's not happening. And that's the complaint a lot of people get about temperature. Like, well, I keep hearing the tone and it's not going up and it's not changing. It's like, that's why the chocolate's so nice. Like, it will be there when it gets there. When it's melted, you may eat it. And so it's kind of a nice way of just peeling people away from those expectations. So raising finger temperature is a little bit more challenging than you think. Autogenics help. Go ahead.
You just have them hold it between.
Oh, in terms of the
How do
chocolate?
you do it?
Yeah, usually I'll just have them rest it gently on their hand. So if you're laying down,
Okay.
yeah.
And they have to put the chocolate
No, I
here
usually
or
have to put it
there?
right in here. Yeah. You can put it on the palm. Your palm's going to be warmer than your fingers, so you can put it kind of right out here. You're kind of with your palms out. So it's fun. I like doing biofeedback, edible biofeedback. So these are the goals that I would typically do. Now, in terms of holding it for longer and longer periods of time, You'll notice that when we start talking about alpha theta neurotherapy, when you look at the traditional Peniston protocol, his requirement before people could pass over to neurotherapy was that they had to be able to do this for 30 minutes and hold their finger temperature at 95 degrees. That's a lot of work. Autogenics help. If you can get people to, if you think about the arteries and the capillaries here, if you can get people to think about their heart, the warmth of their heart emanating out into their armpit and into their shoulder and down their wrists. Sometimes a beach scene is really nice for that. Those are all images that I try to integrate in when we're doing that. Those can be really helpful to just kind of help people notice that. I have Raynaud's, and so it took me a long time to learn this. But when I did, and I did wilderness therapy in Michigan in the middle of winter, so I had these fingers that will just turn like bone white. It's awful. But once you learn it, and once you learn that mechanisms, you can kind of just visualize the blood flow through your arms. You can warm up just like that. But it does take a little bit of practice. So skin conductance, as I said before, if you focus on the numerics, you're not going to get anywhere. So like my skin conductance is 1.95. Focus on the differences in the numbers. Focus on the percentage change. In terms of doing skin conductance biofeedback, I do what I call sumo training, which is not I didn't coin that word, but what that looks like is this. Let's go back and find a session of that. This guy. That eView device is really nice in that you can even use it in the office when you're working with people. So this has got to get jacked up quite a bit here. Let's do the time here so it's a little bit. So with temperature, with skin conductance, often I'll use here's the skin conductance here, and this is the really responsive kid I showed you earlier. He's got to keep it right inside the purple line. And so I can make that purple line bigger or smaller. Actually, it's there's the orange line. There we go. Okay. So when we're doing talk, when we're working with things, I don't know why that is jammed up like it is. Let me fix that. Smooth that out just a bit. There. It's not heavy tonight. The idea being that we'll either use the number or we'll use the feedback, but when he's talking and when we're doing traumatic work, we're not doing EMDR, we're just talking through things, I want him to be monitoring, and we'll be monitoring together, his skin conductance. And so when it goes outside of the box, we're just going to take a break. Take a pause for a minute, let's practice your breathing, and then go back to it again. That's helpful for not necessarily the big traumatic work, but when you've got someone who has been traumatized, and they're stress responders anyway, and you're just trying to teach them to modulate those day-to-day issues. So that's kind of what the skin conductance piece of it looks like. All right. So let's move on to another case. You guys ready for this? You guys doing okay? Yep. No one's too fried. Do I need to give you a break? Are you good to go? Okay, awesome. So, here we go. All right. So, these days I'm in private practice, and I do a lot of teaching and consulting, but for 14 years I worked with juvenile delinquents, and did wilderness therapy, and did counseling, and built a psychophysiology program for a program that worked with juvenile delinquents. So this is one of the kids that came in, and this kid, so he was 17 by the time he got to us. He'd been incarcerated in the state's maximum security juvenile detention facility since age 11. So he's going to max out at age 18. This is a kid that's been incarcerated for for much of his memorable life, and we're going to toss him out in the streets. Exactly. It's unconscionable what we do with our kids. It really is. I felt good being at this place in that at least we gave these kids a lot of tools. And the entire reason that I started doing neurofeedback and biofeedback in 2001 was when I came to this organization, and having been in mental health as a counselor, had really kind of done all the therapies and everything. So I come to these kids, they've had every med in the book. They've been therapized until there's no therapy left. I'm like, what am I going to give these guys? What can I possibly do to give them something else? And so creating the biofeedback, neurofeedback program for this organization was part of my answer, and it actually in hindsight turned out to be a really good thing. So this was Ray, incarcerated since 11. No one really knew what to do with this kid. He was a mess. He had been raped and molested by his father with frequency. His mother was an addict, so she really just wasn't present. Didn't protect him. It was a serious poverty situation. Part of the problem was that they took him out of that home finally. They stuck him in foster care, but he was such a behavioral mess they couldn't keep him in foster care. So he bumped around from foster care placement to foster care placement, and eventually ended up in the system, and actually transitioned to our organization because they said, oh my gosh, he's going to be 18 and he hasn't been outside, and we do wilderness therapy, so we got to get him outside so he knows what outside looks like. So I worked with this kiddo for 2 years, both in doing wilderness therapy. So once a month we went out in the woods for a week with another group, and we come back and we do individual therapy and we do biofeedback, neurofeedback. This kid was on multiple medications when he ate meds when he came, so I don't even remember all of them right now, but I do remember one of them was a very huge dose of trazodone that he took in the morning. And if you know anything about trazodone, it makes you really, really sleepy. And then this kid was supposed to function in class, and of course he was on, I think, stimulant medication as well, Concerta. And I know it was awful. I know he was on Lexapro as well. This kid was on a bunch. So he had these profuse nosebleeds. I mean, like just rags of tissue. So we got him to a psychiatrist, and our psychiatrist brought him down to at least 3 meds, which for that is pretty good, actually. His headaches went away. So let's look at what his brain looked like. So you're going to notice a few little features that we talked about earlier. So Santiago brought up, here we go, these classic beta spindles. Can you guys see that when I highlighted?
Yes.
Yeah, okay. So we have some classic beta spindles. This is an eyes open record, by the way, you guys. And as we move on through, we have tons of beta spindles. Oh, what do we have here? I need to borrow your pointer. Sure. Thank you. So that's P3, C3. And you'll notice as you go on through here, there's a lot of slowing. This is after this kid was off meds, by the way, or on not as many meds. But you're going to see, as you go all the way through here, especially at C3, you've got this big alpha bump, and that's actually what we're looking at right here. That's that C3 alpha bump. So we've got some newish stuff going on. If I look at his maps here, that's weird. You see that big alpha bump right here. Doesn't have a whole lot of alpha, except for in the central area. Activated in terms of beta. And so, looking at this kiddo, we started, and having had a substance abuse addictions history. Not like this kid's had much of a chance to abuse substances because he's been locked up, but don't think for a minute that it doesn't happen. I mean, you have people snorting nutmeg, you have people fermenting their grape juice, and there's all kinds of stuff that gets kind of passed around. So it does happen. So, just thinking about a PTSD presentation, what are some of the features that you're noticing that we've already talked about? Anybody?
You know, or the place.